Okay, so this is a 59-year-old male who presented with gross hematuria, painless gross hematuria for 2 times last month, and so he presented at our outpatient department for further evaluation. So this is his voided urine specimen. So on low power view, for the voided specimen, this is relatively cellular. And most of the cell show prominent degeneration. So you can easily see some cells with prominent chorioresis. And this chorioresis type of pattern is actually a sign suggests that there might be a high-grade lesion in the bladder, because we know that for urine cytology we examine exfoliated cells, so which is usually underwent the terminal stage of their cycle, and usually show prominent degenerative change. And for the high-grade lesion, it's particularly easy to have necrosis pattern. So sometimes in a high-grade using specimen, most of the cell that you can see is these karyoretic cell. So this dirty karyoretic cell is actually a sign suggests that there might be a high-grade lesion in the urine. So when you see these, usually we will, such as like these clusters, see mostly are degenerative, like necrotic debris type of material. So in this background, we will usually want to look for cells that are show relatively preservation, and with hyperchromasia, increased NC ratio, and coarse chromatin pattern. So in a background of prominent degeneration, usually you won't see perfect cells, but these cells all look relatively atypical, with irregular nuclear contour and coarse chromatin pattern. And we just need to look for cells that were more diagnostic. So if this is a reactive umbrella cell, this cell looks relatively abnormal. You can appreciate that it shows increased NC ratio, and the chromatin pattern is also showing unlikely to be like a usual type of hyperchromasia. It shows a relatively degenerative type of chromatin pattern that we call this hypochromasia, and then we can see some condensation over the nuclear membrane. So the hyperchromatic nuclei can be seen in the high-grade urothelial carcinoma, particularly which have degenerative change. So this cell relatively is abnormal. So here we have a much better cell that we can easily appreciate that it is it show prominent increased NC ratio, coarse chromatin, and hyperchromasia. So the NC ratio looks already above 0.7. And in the other circle, there were other cluster of cells showing similar pattern, much more well preservation. So for these specimen, we are going to call this positive for high-grade urothelial carcinoma. And again, this is a high NC ratio cell showing what they called like a jet black type of chromatin pattern. So sometimes it is a little bit difficult to distinguish this from a polyomavirus infection. But you see this is a very high NC ratio, and the background show prominent necrotic pattern. So this type of nucleus is also another type of degenerative change for high-grade urothelial carcinoma. So overall, in the background, we show prominent chorioaceus, and we do see several individual cells showing an unequivocal feature of high-grade urothelial carcinoma. So for these specimens, we will call these high-grade urothelial carcinoma. And this is the first specimen that we receive from this patient in our hospital. So the next specimen is coming from a 61-year-old female, also avoided urine. So she presented with intermittent hematuria for 2 to 3 months. So on low power, we see a lot of squamous cells, particularly the superficial cells. So which means the specimen is likely contamination with gynecologic tract element. However, when we go to higher power, this squamous cell does show some atypical feature. So we have a superficial cell with increased NC ratio and hyperchromatic nucleus. The nucleus is also enlarged with some type of spindle shape. And this is also a superficial cell show increased NC ratio and hyperchromatic nucleus. So for an elder female patient who presented with hematuria, so the only reason for the hematuria might not be just coming from the urinary bladder, and it can also be the first presentation, particularly for the cervical cancer. So when we see the urine specimen with prominent squamous cell contamination, and then we also see some atypical squamous cells that in the pap smear we at least would call these ascus. So we should pay attention. And for these type of specimen, usually we will call these atypical and presence of atypical squamous cells. And we will suggest the clinician to ask the patient to go to the gynecology department for a pap smear. So the patient came to our hospital to the nephrology department, outpatient clinic. So for the nephrology department, sometimes they don't think about the possibility of the gynecology tract cancer. So this has to be like putting in our report to specifically ask them to refer the patient to the to do a pap smear. So for these patients, there's a high possibility that the patient might have a cervical lesion instead of a urinary bladder lesion. So then we move to the body fluid specimen. So this is coming from a young female, 35-year-old only, and who received DNC at the outside hospital with a diagnosis of endometrial cancer. So very young, and nowadays the endometrial cancer patient is getting younger and younger. So she came to our hospital for a radical hysterectomy surgery. So this is the washing cytology obtained during the operation. So what we see here are clusters, three-dimensional cluster of atypical cells showing prominent polymorphism and cytoplasmic vacuolization. So these looks like a tumor cell instead of reactive mesothelial cell. So they were scanned like a cluster of these type of cells. So usually for the endometrial cancer, it is not common to have an advanced stage cancer. So for this young patient, the endometrial cancer is only superficial invasive, and it does not go through above 2/3 of the myometrium. So it doesn't go through the myometrium to the peritoneal cavity. And where is this coming from? So occasionally we will receive early stage endometrial cancer patient with these washing cytology specimen showing cancer, and the patient has received histoscope examination in the other hospital. So the hysteroscope is, when we perform the hysteroscope, we use the normal saline and we dilated the endometrium cavity with normal saline. Just try to see the endometrium with the endoscope. However, this hydropic pressure can also pushing the tumor cell through the fallopian tube and outside to the abdominal cavity. So we've seen occasionally these type of specimen that makes me wonder that hysteroscope is actually not a very good examination for patient, because not uncommonly, occasionally we will see something like this. The other possibility is when we do the operation, sometimes the surgeon would manipulate the uterus and might be like artificially push the tumor cell outside of the endometrial cavity. But this is a relatively uncommon situation. So I personally don't really like the procedure of ureteroscope. So for this patient, the washing cytology is positive. She had the early stage endometrial cancer. The washing cytology doesn't affect fecal stage of the endometrial cancer, but it might affect the treatment of the patient. That maybe sometimes they will use like a high pack, like a hot water washing the peritoneal cavity. Sometimes they will add adjuvant chemotherapy, so we don't know. So that is sometimes quite problematic. So I personally don't like the examination. Yeah. So if I'm a female, I won't receive this type of examination at all. So the next specimen is coming from a 66-year-old female, and this is a pleural effusion specimen. She had a past history of gastric cancer. So just on low power, we can appreciate that there are cluster of cells on abnormal. So this looks like metastatic adenocarcinoma. When we go to medium and high power, the chromatin pattern is very hyperchromatic. And we do see prominent nucleoli, the cell arranged in a cluster and showing highly vacuolated cytoplasm. The nucleoli, the shape of the nucleoli is very abnormal. The contour of the nuclear membrane is also highly irregular. So this is consistent with a metastatic adenocarcinoma. And there were a few cells do show features of a signaling cell morphology. So this is consistent with the metastatic cancer from the gastric origin. So next, this is a pleural effusion specimen. The patient had a history of lung adenocarcinoma. So these specimens show a little bit of drying artifact, but still we can appreciate that there are some tight cluster of cells. So three-dimensional cluster, irregular chromatin with a vesicular pattern, and these cells are all very big and showing prominent nucleoli. So this is positive for metastatic adenocarcinoma and compatible with the patient's history of lung adenocarcinoma. So the next specimen, ascites, the patient had a history of pancreatic adenocarcinoma. So in this specimen, the tumor cells are more prominent in the loose end. So we do the cytospin preparation, and we do see like a irregular cluster of cells with relatively bubbly cytoplasm. The nuclear morphology is kind of polymorphic, and we do see smaller nucleus, much bigger nucleus in the same cluster. So the morphology is consistent with metastatic adenocarcinoma. However, for the pap smear, the preparation is not optimal. So supposedly we will have a small circle over here, but when we smear the material, it's go further, and it's I call this like a jumping off the cliff. So when we do the smearing, sometimes if it is too sticky or it is too like a scan, we can put a little bit of normal saline on the specimen just to facilitate the smearing. Otherwise, all the tumor cell will jump off. So we do not see any tumor cells from the pap smear. And this is the cell block preparation. So in the cell block, we do see similar cluster in the loose end. So vacuolated cytoplasm in a tight cluster, and the morphology is consistent with the pancreatobiliary origin cancer. So for this specimen, we are still calling these positive for adenocarcinoma. So you see this tight tubular structure, and this one as well. So this is positive, and the morphology is consistent with pancreatobiliary origin. So sometimes the reason that we do two different type of staining pattern is occasionally you will see one of the preparation, one of the staining is not optimal, and you will need to see the other specimen for the diagnosis. So next specimen, this is also a peritoneum washing specimen. The patient also has endometrial cancer, but this time, just based on the operation notes, the cancer is in high stage. It already showed omentum cake, unlike the prior specimen, the prior patient, that it is very clean throughout the entire abdominal cavity. So for these peritoneum washing cytology specimen, again, we see very tight cluster, three-dimensional, and with atypical cells showing vesicular chromatin and prominent nucleoli. The cytoplasm is vacuolated, so this is positive for adenocarcinoma. And because during the operation, they already see the omentum cake, so this is positive for adenocarcinoma for sure. So again, this is pleura effusion specimen. Patient had a history of lung adenocarcinoma. So just on low power, we know that this is metastatic because we see the two cell population. So the second population composed of these hyperchromatic tumor cells in cluster with vacuolated cytoplasm, and the nuclei are all very atypical with prominent like polymorphism. So this is consistent with metastatic lung adenocarcinoma, and this is a low power diagnosis. So for the cell block, we do see plenty tumor cells, so these can be used for testing for the resistant mutation. So let's move to the finding the aspiration. So yesterday, we've seen a parathyroid lesion presented as a thyroid nodule by the clinician, but this is a very typical morphology for a parathyroid lesion. So we perform immunohistochemistry with the residual liquid specimen. So this is GATA3. So the GATA3 shows diffuse nuclear expression, support the diagnosis of parathyroid lesion. And the parathyroid hormone, this is a hormone, so this is cytoplasmic staining. So we can appreciate that in the and in these cells, we do see prominent cytoplasmic expression of PTH. So this is indeed a parathyroid lesion. So we will sign this out as a parathyroid lesion. For these specimen, we don't use Bethesda system because this is not coming from the thyroid. So our routine report is that this is negative, and this is consistent with the parathyroid lesion. So we use lesion and suggest clinical correlation. And the clinical correlation, this is a secondary parathyroid hyperplasia. So this is a nodular hyperplastic parathyroid gland. So the next one, again, this is a thyroid aspiration. So low power, we don't see a lot of colloid. We have some cells, but the cells seems to be in the clot. So if we go to higher power, so we see this tight cluster of cells. The cells do show irregular arrangement, like a sort of like a drunken honeycombing, and the cells show elongation and a relatively irregular nuclear contour. So additionally, we see some of the intranuclear pseudo inclusion here and there, but this is in the clot, so relatively indistinct. However, I think we can all appreciate that, yeah, so another pseudo inclusion over here, and another one over here. Yeah, so the cell does show diffuse feature of papillary thyroid carcinoma, and quite common the pseudo inclusion. So because the cell we already have enough of cells and enough of pseudo inclusion, so we will sign out the case as positive TBS6 for malignant and papillary thyroid carcinoma. So the next specimen is relatively difficult. It's also coming from the thyroid. So first of all, in the background, no colloid, hypercellularity. And we see quite a lot of cells arranged in cluster and some papillary architecture as well. So the cell show, I think we can all appreciate this like a delicate papillary structure, and we can see some vasculature going through this papillary structure. So the lesion does has a prominence. So this is a fibrovascular core, and this is a fibrovascular stalk. So indeed, this is a papillary arrangement. But when we go to the individual cell, first thing is that we do have a lot of these associated cells in the background, which is relatively uncommon in the papillary thyroid carcinoma. Additionally, most of the cells do show abundant granular cytoplasm, and the nuclear feature, we do see distinct nucleoli in almost every cell. So the cell do have an oncocytic morphology. So what are we going to call this lesion? We do see prominent papillary structure, and additionally, in addition to this papillary structure, we have these. So this is capillary meshwork, and the cells are all detached. So we have a few areas showing relatively preservation of the lining cells, but this is more like a vascular meshwork, and with most of the cells detached and in the background. So the pattern is relatively uncommon for papillary thyroid carcinoma. However, in some of the cell, it does show some nuclear feature that you would suspect to be a papillary thyroid carcinoma. So for this lesion, it shows mixed feature of oncocytic tumor, because oncocytic tumor is oftentimes highly vascular. So you can see a lot of these fragments of capillary in the background, and sometimes it will present it as a transgressing vessel through a bigger fragment. But additionally, the papillary structure and some of the nuclear feature, including elongation, including some groove, seems to be a little bit like a papillary thyroid carcinoma. So there were a couple differential diagnoses. First, this is a this is an oncocytic tumor. The second is that could it be a papillary thyroid carcinoma, but it is an oncocytic variant, a Herzl cell variant of a papillary thyroid carcinoma. So I checked the image. The image is not so we also see a pseudo inclusion over here. But occasionally, oncocytic tumor can present also with pseudo inclusion. So for this case, we can either call these suspicious for oncocytic tumor, or we can call these TPS4 suspicious for oncocytic tumor, or we can call these suspicious for papillary thyroid carcinoma oncocytic type. So the image finding do not suggest that this is a follicular tumor, because it shows a coarse like a calcification. So I think overall maybe we should call these suspicious for papillary thyroid carcinoma oncocytic variant subtype due to the presence of these pseudo inclusion. So this is a relatively uncommon case. So next, this is a parotid gland aspiration. So we see some blood in the background and some cells as well, relatively hypercellular. And here we start to see this chondromyxoid type of matrix material, and with the oval shape of myoepithelial cell with very close relationship with these stroma. So in the background, we have myoepithelial cell presented with a plasmacytoid feature or a spindle cell feature. And throughout the specimen, we do not see any high-grade nucleus, so this is unlikely to be a carcinoma X pleomorphic adenoma. So for a pleomorphic adenoma, we will usually want to see the loose stem demonstrate these magenta color extracellular matrix material, and we also see the myoepithelial cell. It almost looks like lacuna cells embedded in this fibrillary extracellular matrix material. So this is consistent with a pleomorphic adenoma. So this is a benign case. So the next specimen is neck level 2 mass lesion with aspiration cytology. So they didn't specify whether this is a lymph node or what nature is this lesion. So according to the sonography, this is almost 4 centimeter mass lesion. So in this aspiration cytology, we see mostly necrotic cells in the background, and a lot of cells presented with this spindle cell morphology with a nucleation. So when we examine this type of specimen, we will always want to look for relatively preserved cells. So for these cells, this is a typical spindle-looking cells with a very hyperchromatic nucleus. So this looks like a typical squamous cell. So in the background, we do see a lot of these hyperchromatic cells with a relatively pycnotic, like a shrinkage of the nucleus, but the hyperchromasia is quite prominent. So these all looks like immature squamous cells with a nuclear atypia. So the patient do have a history of squamous cell carcinoma, but this is 20 years ago. However, for patients who have head and neck squamous cell carcinoma, it is not uncommon that he will develop a second primary lesion, because usually these kind of patients have the exposure to certain carcinogens such as smoking. So this is still possible to be a metastatic squamous cell carcinoma from another primary. So based on the image study, there seems to be a lesion in the oropharynx. So this might be a new oropharyngeal squamous cell carcinoma, and with a level 2 lymph node metastasis. So for this case, I think we are going to call this suspicious for metastatic squamous cell carcinoma, because we don't have more to see. We can only see very scant these typical squamous looking cells. So this is what we are going to call the case. So that's for all the case today. Thank you.